So, how does the proposed treatment advance the stated goals? What are the goals in treating any illness? Usually curative. If so, if it's possible, curative is the way to go. If cure is not possible, then palliative goals come into play. Preventive goals don't usually come up in the hospice situation or end of life, but they are major goals of our medical system. And they come into play for most of a patient's life. So how does this apply to feeding tubes? Well, what is the goal with a feeding tube? They were never intended to merely prolong life at the end of a terminal illness. That's abuse of a feeding tube. Is that what the patient and family want, to prolong the dying process? In this instance, can we both extend life and alleviate suffering? Sometimes in this circumstance, if you extend life, you worsen the suffering. What will the feeding tube accomplish in this particular case? Will it alleviate hunger and suffering? Very doubtful. Terminally ill people don't feel hunger. And so far as we can tell, the processes that go on at the end of life are not painful. Will it make the patient more comfortable? Most patients seem to find feeding tubes to be an irritant rather than a comfort. All you have to do is watch how many try to pull them out. Will it lengthen life? Studies have repeatedly shown that Alzheimer's patients don't live any longer if you use a feeding tube. Well, why not? That doesn't seem to make sense. Certainly a patient should live longer if you feed them than if you don't, but it isn't true. They die from aspiration pneumonia. Sometimes aspiration pneumonias may be the reason a feeding tube was selected. But will it prevent aspiration? That can frequently be the reason for insertion. There is no evidence that it can accomplish that. It may actually make aspiration worse. Numerous studies are showing no benefit to feeding tubes except in conditions where the dysfunction is not permanent. Cancer in feeding tubes. Cancer cells are, by definition, among the fastest growing cells in the body, and they will use the lion's share of the calories that you're providing with a feeding tube. Metaphorically, using a feeding tube for a patient with metastatic cancer is a lot like standing in front of a fireplace and throwing kerosene at it. You are feeding the feeding the fire. When might a feeding tube actually be in a patient's best interest? Well, when the quality of life is pretty good and the patient cannot eat by usual pathways. For example, somebody who has a severe chemical burn of the esophagus that resulted in scarring and closure of the esophagus could live for years if nutrition is provided via a feeding tube. I'm all for it in that instance, if that's what the patient wants. Sometimes it's in a patient's best interest when they can understand the decision to use the feeding tube and they support it. Sometimes with GI cancers, like esophageal cancer or stomach cancer, that prevent swallowing because they mechanically obstruct the passage of food, a patient could live much longer and pretty decently if food is provided via a feeding tube. In those rare instances, feeding tubes may help the patient. Alzheimer's disease and metastatic cancer do not fall into those categories. Let's talk a little bit about ALS patients. Amyotrophic lateral sclerosis. With ALS patients, feeding tubes may actually increase survival. Well, that's a mixed blessing, and that may not be the patient's goal, and that may not be the family's goal, and I don't think it would be my goal, although you can't tell until you're in that circumstance. It certainly does not help the quality of life, and it may increase suffering by causing aspiration so much. Surrogates may decline any treatment they wish to decline. The exceptions to that are very rare. Things like treatment of tuberculosis when it's a public health hazard may be an exception. But feeding tubes, and for that matter ventilators, they are not exceptions. Surrogates may decline those by Delaware law. The surrogate should explain to the medical team why they don't want the treatment for their family member. They should acknowledge the consequences and that they are ready to deal with those consequences. They should make sure that there is a family consensus, at least to the extent that that's possible. They should refuse permission, And if the issue is still unresolved, if the family is saying no and the medical team is not respecting their decision, they should ask the ethics committee to look at the case. And finally, a good relationship with your patients and their families is indispensable in helping those families make appropriate decisions. The best guard against bad decisions being made by patients, families, and surrogates, or good decisions that end up being ignored by the medical team, is to have a good relationship between the patient and the family physician. And for that matter, between the patient and whatever specialists are serving the patient. The good relationship will overcome all the fuzzy technicalities of the law. And after all of our goals should be the same: to help our terminally ill patients make tomorrow a better day than today was. Thank you very much.